For the next talk, it is my profound privilege to invite Dr. Sunil Mishra, who has been my mentor and teacher and is currently heading the Department of Endocrinology as a director at Medanta, the MedCity. Welcome, sir.
Yes. So, thank you, Dr. Prajita, for kind introduction. And I will be talking on non-critical yet critical, that is managing the in-hospital hyperglycemia care, which our job to day-to-day affair, and it has taught us many lessons. And I will be presenting the how we do manage our patient with in-hospital diabetes care, and also will show one of our study which has been accepted as a in ADA conference, and some new advances in hospital diabetes management. So we know why it is important to do that, because this is the time when people are receptive to you, because at that time the glucose level are high, they are in hospital, and despite that it is a brief time for them, but it gives an enormous amount of information, as well as their receptiveness towards the long-term care. It is also important for you because it is trial after trial, the mortalities has been shown higher people with diabetes, as well as the new onset hyperglycemia, be it as a patient with normoglycemia compared with the diabetes, as well as when a new onset hyperglycemia has also been seen, and a glucose level if it's more than 200 on admission, as well as if it is below 200. So presenting you a prototype case, a 40-year-old male who is hypertensive, admitted in the ward for PUO and 3 months duration, and appetite is mildly reduced, and you check his glucose, and glucose you found 150 milligram per deciliter. So what you will do, how you will classify? Will you tell him diabetic, non-diabetic? So we will do HbA1c, we will do blood glucose monitoring, start treatment for hyperglycemia, we will do both, and if RBS is normal, no need to further testing for glucose. So these questions I will try to answer during the course of the presentation. So you do HbA1c, of course, and you get it 7.5%. And you asked for the 24-hour profiling of by the glucometer. So pre-breakfast 160, lunch 200, before dinner 220, and post-dinner it is 240. So now the question is that how you are going to manage, and this is what we are going to discuss. Start oral anti-hyperglycemic agents, start sliding scale insulin, basal bolus insulin therapy, start premix, and only the basal insulin. Okay, so inpatient hyperglycemia in non-critical care settings. So the question is that how frequent it is. So how to diagnose and how we are going to manage it. So now, studies from the West as well as from our hospital have shown approximately around 30 to 40% of the in-hospital setting people are having hyperglycemia, whether they are diabetic, new onset diabetes, or in-hospital hyperglycemia or stress hyperglycemia. And this is one study by Dr. Umpiraj, and in our own data from hospital, 40% of the people are having hyperglycemia. In our day-to-day practice, our team does see approximately 120 to 150 individual in a hospital for management of the diabetes. So now the question is that how to diagnose this in-hospital hyperglycemia. So this individual is having 150 and coming for first time, right? So these are the few definitions which you can remember. The hospital hyperglycemia is that any blood glucose value more than 140 milligram per deciliter is hospital hyperglycemia. Stress hyperglycemia is that glucose is elevated for first time, but you get the HbA1c, and HbA1c you found is below 6.5%. So patient might be having a stress hyperglycemia. HbA1c value, if is coming above and equal to 6.5%, it is prior history of diabetes is there. Hypoglycemia is defined any glucose value below 70, and severe hypoglycemia irrespective of the symptom in a hospital is defined as below 40. So how you should go ahead in like this patient recognizing and diagnosing the in-hospital hyperglycemia. So upon admission, all patients like vital, blood pressure, pulse, temperature, the glucose should be assessed, and history of diabetes should be taken from patient. And if there is no history of diabetes and you measure the glucose, it is below 140 milligram per deciliter, you may initiate the point of care testing according to the need. Like if some patient is started on a steroid or pulse steroid therapy, you may go for the point of care testing. But if you get no history of diabetes and glucose level is more than 140, you start POC and get it continue for next 48 hours or 72 hours and check HbA1c. And if you get blood glucose above 140, HbA1c less than 6.5, you may call patient as stress hyperglycemia. And but if HbA1c is more than 6.5%, patient is still diabetic at this point of the time, and continue ongoing point of care till the time patient is having with you in a hospital. And if it is above 6.5, you will go to the last column, that, or if there is a diabetes history, check A1C. If not available in last 2-3 months, as Dr. Deepak is telling, that patients have getting HbA1c once in a year, and continue with the point of care testing as per the requirement. Now coming to how do we manage the hyperglycemia in a hospital care setting, and especially non-critical care setting. So first thing is that we should know the targets. Like we did HbA1c, we have done the random glucose. So the fasting and the preprandial target should be kept as below 140 milligram per deciliter, and modify therapy. If the glucose is going below 100, you need to modify, because you may end up with a hypoglycemia. Maintain the random blood glucose or bedtime glucose below 180. More stringent control can be done for who are patients who are a bit tightly controlled, and patients who are sick, patients who have other comorbidities, a less stringent control is required for them. There are multiple factors associated with the in-hospital hyperglycemia, because this is a moving target. It is very difficult to control hyperglycemia in hospital. Patients going for investigation sometime. They are kept nil parolary for some other investigations, and then they are given some feed which you have very little control. And they will be given snacks, which of course you try not to have them, but yes, they get in hospital the same. So type of diabetes, patient current glucose concentration, prior treatment, can clinically assess severity of the illness and expected calorie intake during the acute episode. These all things keep changing, and that's the thing is hitting a moving target is the in-hospital hyperglycemia, but it is again important. Monitoring glycemia in non-critical care setting is recommended. Schedule is that patient should be tested pre-meal and bedtime, and patient who are on nil parolary, at least 4 to 6 hour monitoring is required for them. Now how we are going to treat them? So pharmacological treatment for in-hospital hyperglycemia in non-ICU setting is that we may go for oral anti-diabetic drug, but generally not recommended, because there are different aspects of the oral anti-diabetic drug. Except for a patient who is coming for the daycare procedure, you may continue with the oral anti-diabetic drug if patient is having a stable control. And the most importantly, the insulin is the subcutaneous insulin is the required treatment for patients with the in-hospital hyperglycemia. Continuous insulin infusion, if required, you can do, but you need to have the team, and you need to have the good monitoring, and you need to have good algorithm to adjust the insulin dose, and education and the confidence of the staff is very important for that. So therefore, the insulin therapy is the baseline for treatment for in-hospital hyperglycemia in non-critical care setting. Sliding scale, basal bolus therapy, or premix, what should we do? The treatment of choice is the basal bolus therapy or multiple daily insulin dose adjustment. Why not the sliding scale insulin? This looks very easy. You write at anywhere in the hospital, and anyone can continue it, anyone can apply it without putting any mind on it. You just write any scale, right? 2, 4, 6, 8, 10. And in our during our MD days, we ask our seniors or the chief resident, sir, please give us some sliding scale insulin, how we'll write. And later on, now we know this should not be used at all, because this is a reactive approach. Why? So if you look at here, you are not treating, not giving insulin, allowing glucose level to go high, then you are giving insulin, probably at a high dose, and then it will come down, and then you will not acting here, and then your glucose level is going up. And this is how the somersaulting keep happening with the sliding scale insulin. It can cause both hypo as well as hyperglycemia, and glucose levels are less well controlled. Very well shown in by Dr. Umpires. You all know that Dr. Umpires is one of the leading authority in a hospital hyperglycemia management. This is RABBIT-2 trial. This is a randomized study of the basal bolus insulin in inpatient diabetes management. They took 130 non-surgical patients who were insulin naive, and they were randomized with the sliding scale insulin versus the basal bolus therapy. So as you can see here, the blue one is the sliding scale insulin therapy, and the yellow one is the basal bolus therapy. After 4 days, there is a significant difference in the glucose level between the two arms, and as we can see here, that the target glycemia was kept below 140, was achieved in 2/3 of the patient with a basal bolus versus only 1/3 of the patient with sliding scale insulin. Some 14% or 9 of the patients who were on sliding scale were still having high glucose. They were rescued by the basal bolus therapy, and they showed a better control. Hypoglycemia was no different between the two arms. So this suggests that in hospital, this basal bolus therapy is the gold standard for the treatment. Now, how to use insulin? So there are three things in the in-hospital hyperglycemia. In OPD setting, we have a basal insulin and bolus insulin if we are using multiple time. For hospital, we have one more additional here, that is the correction insulin. Basal insulin is like you use Detimir, Glargine 300, Degludec, or NPH. Nutritional or prandial insulin is you may use the rapid acting insulin, regular insulin, or now with a faster version of the fast acting aspart or the fast acting Lispro, which is not yet available in India, or the other available insulin. Correction insulin is that you are monitoring glucose at different point of the time, but you don't want to wait for glucose to remain high, and you correct for that high glucose same then and there itself. Right, that's the correction insulin. Now coming to the case, I've already gone through the case. This 40-year-old gentleman coming with PO admitted and found to have a glucose level of 150, HbA1c is 7.5, and this is the glucose profile. So how you are going to treat this patient, right? So of course, now we are educated. Now we know that we should start the basal bolus insulin therapy, and this is how we do in our hospital. We have a glucose chart where different time the glucose is written, and then the insulin dose is written here, and this is the correction scale for various glucose. We used to keep it 100 to 180 as the same, and then we keep deducting or adding insulin level, the mealtime insulin or the prandial insulin based on the glucose value. So I wrote the patient the fast acting aspart and the Degludec like 6, 6, 4 and 16. These were the glucose value 180, 250, 160 and 180. So what nurse did, because it is 180 falling 6 unit, but when it came to 250, instead of calling you, they know there is a correction scale there itself, so they added 4 units, so it ended up with a 10, and 4 before dinner, because now immediately you correct it, and then 16 bedtime. You go next day, because you found that the fasting was high, you increase the Degludec by 2 units, and now see the glucose value. 160 in the fasting, 220 is again high here. This time the 2 correction was done for fast acting aspart, and we continued with the 4 and 18 bedtime. Third day, we write this, the glucose values are better. So this is how it's keep happening, and you keep correcting, and you keep accommodating the previous day's insulin adjustment correction done by staff in the next day chart, and you can get a good glucose control in short span of time. So coming to the next leg is the benefits of the newer analogs. So we have the newer long-acting analog and the short-acting analog, and that's what we are going to discuss briefly. So just briefly summarizing here, these are important metrics of the basal insulin. Degludec action starts steady states achieved in 2 to 3 days. Glargine 300 in 3 to 4 days, and Glargine 100 in 2 to 4 days. Onset of action of the Degludec is quite fast, 0.5 to half an hour to 1.5 or 90 minutes, whereas the Glargine 300 in 2 to 6 hours and 2 to 4 hours for Glargine 100. Right. So this is one study done by Dr. Umpiresh, where they compared the Glargine 100 versus Degludec 100 in how early the Degludec 100 gets into glycemic control. So what they found that within even a single first day, the glucose level decrease in the arm where they have used the Degludec 100. So our thinking is that because it's a long-acting insulin, it will take a little longer to get into a steady state. It was not. Now it's a trial after trial is showing that these ultra long-acting insulin are able to quickly get into the glycemic control and with less variation, and I am going to show that. So this is our study. This is randomized control trial. We registered into the clinicaltrial.com, and this is the timeline. The recruitment completed, and we have first pooled and last updated. It was in 4th of March 2022. and this is the study. So this is efficacy and safety, and this has been accepted in ADA conference this year. And efficacy and safety of the degludec U100 versus glargine 300. Why we are doing it? Because there is no head-to-head trial comparing the degludec versus degludec 100 versus glargine 300. There have been trial comparing degludec versus glargine and glargine 300 versus glargine 100. So we compared for in-hospital for first time the degludec 100 versus glargine 300 in hospital management of the type 2 diabetes. This is prospective open label non-inferiority randomized control trial. Type 2 diabetes patients who were undergoing coronary artery bypass graft were taken. 239 subjects were enrolled, and equally 1:1 randomized done in the both arm. And randomized done was on a day 2, and they were be on between 5 to 7 days. They were on the in a hospital duration. This is the hospitalization. They were in the degludec insulin and glulicin, and other arm was glargine 300, and the insulin glulicin was equal in same in both. After their discharge, they were again on the same arm. There is no crossover was done. This was the post discharge. Insulin dose adjustment were done, and we also did the CGM by FGM we put on the day 2. This is the beautiful thing what we have learned from here. So you see, as we have thought that it will take a little more time for these insulin like 3rd and 4th day to get the steady state. No. From even the day 1, you can see the flat arm, flat curve between the glargine 300 and also the degludec 100. It is coming flat and maintaining a steady state level of the glucose around 160 till 12th day of the after the procedure. When we compare the glucose level at different point of the time, pre-breakfast, pre-lunch, pre-dinner, as well as we did for the first time the 3 a.m. glucose in all patients. So there was a difference in the pre-breakfast level between the degludec 100 and glargine 300. At pre-lunch, pre-dinner, and at 3 a.m. there was no significant difference between the two insulin. So that means to say that both insulin control glucose very well, and there was a little better control in the level in the pre-breakfast with the degludec 100. We also looked at the hypoglycemia. There was no significant difference in the hypoglycemia. Numerically, there were lesser hypoglycemia with degludec 100 versus glargine 300, but there was statistically no difference. So this is our study, and probably it will get published in some of the reputed journal. Then we'll share, and it is being will be presented in ADA conference this year. So take-home message is that upon admission, assess glucose level and take diabetes history for all patients. Glucose is a vital for individual because it determines the mortality as well as morbidity. Get HbA1c test done. Target glucose in non-critical care setting is between 140 to 180 for most non-critically ill patients. Insulin therapy is the preferred method for glycemic control, and scheduled subcutaneous basal bolus insulin therapy is effective and safe, and sliding scale should be inappropriate. It is inappropriate and should be discouraged. Thank you very much for your kind attention.
Thank you, sir. You have explained beautifully how to manage a patient in hospital settings, especially in non-critical settings. One thing, sir, in your trial, you involved the CABG patients. So was it a subset of the patients or all the patients you took of CABG only?
All the patients of the CABG.
Any particular reason for CABG patients?
Because we have a better structured program of the CABG. Their length of the hospital stay is very well determined. And regarding if we take other patients, their length of hospital stay, their post-discharge follow-up is more variable. So for us, it was because of the ease of doing. So they stay for around 12 days to 14 days near the hospital after admission, including for the discharge. So easy and ease of doing the trials, that was the reason for it.
Wonderful study, sir. Thank you, sir. We can have questions.
Thank you, Dr. Sunil, for this nice presentation. I'm Dr. Sushil Kotu.
Yeah.
Those patients who are admitted in wards with non-critical sickness, once these patients are admitted, how to calculate the total amount of dose? You have not mentioned how to calculate the total amount of dose, whether the patient has normal BMI, the ideal body weight, or the patients are obese or having CKD. And in addition to that, you are mentioning about the correctional dose insulin. You have a chart, a fixed chart. Instead of that, it is better to use a formula to calculate the correctional dose for these type of patients, which can be very much dynamic sort of process. It can't be a fixed dose for the different sort of patient population.
Thank you. Very good question. So first thing is that regarding probably because of the positive time, I have to cut down the slide and to show the something new data. So how to calculate the insulin dose, that's the most important thing, how to start. So usual thing is that if you are using insulin for first time, you can go for 0.4 unit or 0.5 unit per kg per day and divide it in 3 boluses as well as 50% as a basal insulin. So that is one way of doing things. But there are patients who are already on insulin, and you can calculate their insulin, total daily insulin dose requirement, their HbA1c, current HbA1c, and their body weight. There are BMI based. If your patient is having overweight and obese, you can go little 0.6 or 0.7 unit per kg. If your patients are lean and thin, you can go down. Similarly, if the patient is having compromised kidney function, EGFR is low, below 60, so you will definitely deduct the total daily dose requirement from that. So it is well accepted, well known, and that is what we do in our day-to-day practice. Regarding the correction, we don't have a flexible correction. We don't write because it's our fellows and our DNB fellow who are pursuing their DNB in endocrinology, and our team look after them. And we have a total flexibility of correction insulin dose. So correction insulin dose we calculate on based on many things. If what was the response of the glucose, as you've been talking, there should be a formula to calculate the correction insulin dose. If the patient is having CKD, so probably we may write +1, +2 or +3. We not go for 2, 4, 6 units. But if a patient is on a steroid and patient is showing a very high glucose level, so we may correct more aggressively like 4, 6 and 8 kind of the thing. So it all is variable. That correction part is blank, and we decide based on the response of the insulin from the previous days and the disease and the drugs which patient is taking.
Thank you.